Welcome to the multiple Syndemics of Tuberculosis Symposium, day 2. It is Thursday, the 11th of September. I begin by acknowledging the traditional owners of the lands on which we gather today, and I pay my respects to elders past and present. I am joining you from the lands of the Bunwurrung people of the Kulin Nation, and I acknowledge that this land, as with many across Australia, was never ceded. My name is Gail Cross. I'm an ID physician and clinician researcher based at the Burnet Institute, Monash Health, Monash University, and the Kirby Institute in Australia. I live in Melbourne, where it is 4 p.m. in the afternoon and the sky is shining today. And I'm delighted to welcome you today on behalf of the indomitable Michaela Coleman, the TB CRE Next Generation Committee, the Implementix Change, and the Australian Clinical TB Research Network. I'm also joined in spirit by my co-host, Dr. Andrew Burke. Andrew's a respiratory and infectious disease physician and clinician researcher who unfortunately could not be here today. Like me, he is passionate about finding better treatments for people affected by tuberculosis. The purpose of this symposium is to highlight that TB doesn't occur in isolation. It is a complex disease with deep connections to many other social and biological conditions, and it leaves a lasting impact on people and their families far beyond the 6 months of treatment that we give them. Over the next 2.5 hours, we will explore TB syndemics, integrated screening, and models of care. And I encourage you to stay for the panel discussion in the last 30 minutes of this session, which no doubt you will, because it promises to be rich and engaging. Just a few housekeeping notes. Please keep your audio muted. Post your questions in the chat where they can be answered in real time during the session. And answer may also be answered in the posts by the speaker after their session, or it could also be put up during the panel later today. You may be invited to unmute and ask your question directly, so perhaps get your lippy on now if you wish.
Good morning, everyone. Thank you for having me, and thanks, Michaela, for the invitation. My name is Marcello Scopezzini. I'm a clinical research fellow and infectious disease physician, and I'm completing my PhD both at the London School of Hygiene and Tropical Medicine and at Zambart in Zambia. And today, I wanted to touch on where we were with the evidence around TB and cardiovascular disease, particularly looking at some epidemiology, mechanisms and etiology that underpin this relationship. We'll take a brief look at LTBI and CVD, and then some suggestions for future research and where I am with my own research currently. So in terms of TB and CVD, this is actually already an established syndemic in many countries across the world. If you look at cardiovascular disease mortality in the most populous countries across South Asia, Latin America, CVD is already the leading cause of death. And TB and respiratory infections remain important causes of death, but have dropped down the rungs. If we look at sub-Saharan Africa, respiratory infections and TB remain the leading cause of death, but cardiovascular diseases are really catching up quite quickly. And why this is important is that CVD mortality and burden is increasing very rapidly across the world, and it's increasing the fastest in these low and middle income settings where healthcare infrastructure is not really quite geared yet for this onslaught. And so TB and CVD really are two established important problems across the bulk of the world's population. What do we know about associations between TB and cardiovascular disease mortality so far? So I've selected these 3 studies to go through in a little bit more detail, starting particularly with Basham et al.'s study in 2020 that showed in a large systematic review and meta-analysis that there was a 1.5 increased risk of CVD morbidity and mortality in patients who had had any history of TB. And Romanovsky et al. Slightly earlier had actually found that up to 20% of post-TB mortality is attributable to cardiovascular disease. And finally, a third systematic review more recently has found an overall prevalence of CVD of up to 11% in patients with TB. So what this is telling us is that there is certainly an association between prevalent cardiovascular disease and TB and mortality and post-TB mortality. But some of the drawbacks of these studies is that most of this evidence comes from high-income settings and low burden for TB settings, where there's probably a different risk factor profile and a different epidemiological profile. It also doesn't really give us any evidence around causal relationships. Thinking a bit more closely about causal relationships, we have a very recent study from Julia Critchley et al. In 2024 that was a large retrospective data set cohort looking at American and UK health records data. And the headline here is that the cardiovascular disease incident rate ratio was more than threefold higher than the general control population in the US and just under threefold higher in the population in the UK. I think what's really interesting in this study is that the authors also looked at the temporality of this risk and showed that cardiovascular disease incidence increased significantly immediately before and during the acute TB treatment phase, and then declined again, but still remained higher than the general population. So the strengths of this study are that obviously this was a very large data set, matched cohorts. They've adjusted for many CVD risk factors, and they could take into account reverse causality with their incident risk rate ratio calculations. But some of the drawbacks, again, are that this remains high-income setting data, and that many CVD outcomes may not have been captured because this was retrospective records data. So we've talked a bit about prevalence. We've talked some about incidence. So let's look at CVD risk factors and their prevalence in patients with TB. I've selected Baluku's et al.'s systematic review because it came from Africa and it pooled data across multiple African countries looking at CVD risk factors. And indeed, it showed that these are prevalent in patients with TB across the African continent. We've also had very good evidence from yesterday's talks that smoking is associated with TB death and incident risk. And of course, we've known for a long time that smoking is extremely closely associated with CVD risk. And finally, we can't not mention diabetes and its relationship with both TB and cardiovascular disease. And we know that there's a very strong bidirectional relationship between TB and diabetes. Again, even with these three systematic reviews, they're limited by heterogeneity. There's only one systematic review that has looked at data from African studies, and they probably underestimate the prevalence of risk factors across the TB population. So now we've covered prevalence, incidence, and a bit about risk factors for CVD, but what do we actually mean by CVD? And I think this is a really important part of the discussion. Often what we mean is atherosclerotic cardiovascular disease, which goes on to lead ischemic heart disease, which of course is the leading cause of CVD death globally. And it's one that we're most familiar with as physicians, particularly in high-income settings. We know a lot about traditional risk factors that underpin this relationship, and we've looked very closely at infections, chronic infections like HIV, and their increased associated risk, and their risk of increased cardiovascular disease. We need to talk about heart failure burden as a second large entity that is much more diverse, has many more etiologies, has much more unreliable prevalence statistics, particularly in lower income settings. And why this is important is that ischemic heart disease is by far not the leading cause of CVD burden across continents such as sub-Saharan Africa. And there's a much more diverse etiological base for heart failure disease, heart failure burden. And then there's a whole group of other conditions, and these include rheumatic heart disease, cardiomyopathy, and pericardial diseases. And here we know that the relationship between TB and pericardial diseases is very well established. But all of the previous studies that I was presenting to you was looking at this relationship with atherosclerotic cardiovascular disease, where we've got much more limited evidence. So let's talk about where we know the evidence definitively exists. In terms of etiological pathways, just to go through it very briefly again, we know that TB is related to pericarditis and causes pericarditis. We have some evidence of a relationship with myocardial disease, right-sided heart disease, And there's this possible association with atherosclerotic cardiovascular disease. And together, the way that TB is going to contribute to CVD burden is probably more in the context of heart failure than it is in terms of ischemic heart disease, at least with the available evidence that we have for now. Talking specifically about TB in the heart, let's look at the evidence base here. We know that in approximately 1% of cases, TB will specifically directly attack the heart in a condition called TB pericarditis. And this condition carries an up to 40% mortality. And we've had lots of studies over the last 10 years, led mostly by Mayosi et al.'s team in South Africa, that showed that steroids really play a role in improving mortality and reducing morbidity in TB pericarditis. And this is counterbalanced with some evidence around mortality and untreated HIV. And a lot of the studies that look at the incidence and prevalence of TB pericarditis are not also looking at what co-prevalent cardiac pathology is occurring in patients with pulmonary TB. And why this is important is that if we think about the burden of TB disease, of course, the largest single population are going to be patients with pulmonary TB disease, and we know very little about coexistent cardiac pathology in this group of patients. But we do know a little bit more than we think. There are two Zambian studies, Bates et al. And Muchalinganga, that have shown that up to 7% of patients in pathology series have evidence of cardiac involvement at TB death. And then this all led me to undertake a systematic review that I published last year to try and establish the prevalence of cardiac pathology based on imaging and biomarkers in patients specifically with pulmonary TB. And what I found is that indeed pericardial effusion is co-prevalent up to about 40%. Sorry, I forgot to put in the figures for my own study. And to a lesser degree, so is left ventricular systolic dysfunction. But where I was quite limited is that there is actually really a dearth of data to underpin this relationship. I only found 7 studies, and I couldn't take these studies to meta-analysis. So I hope I've given you a bit of an overview of etiological mechanisms and how we need to think more broadly than just atherosclerotic cardiovascular disease and take into consideration heart failure burden and how this is related to TB burden. And to do this, I wanted to illustrate a more recent study from Zambia by colleagues Samim et al. That recruited 286 participants with pulmonary tuberculosis in Zambia and South Africa, about 40% of whom were living with HIV. This was pulmonary TB patients who were consecutively recruited, and they all underwent a standardized assessment to detect cardiac pathology. And what they found is that in this consecutive series of systematically recruited patients, almost half had evidence of a pericardial effusion, a third had some form of pericardial thickening, and 1 in 10 had evidence of constriction at the start of TB treatment. And what's interesting is that at the end of TB treatment, many of these pericardial effusions and some of the pericardial thickening improved with TB treatment, but constriction remained an ongoing concern. And again, this is really an important study because it's demonstrating for the first time in a systematic form, in a systematic recruitment, that constrictive pericarditis may really be a significant cause for concern in patients with pulmonary TB. It's limited by a lack of a control group and some significant loss to follow-up, but nonetheless, this is an important study to think about in terms of the etiological causes underpinning this relationship. And finally, very briefly, touching on LTBI and CVD, very briefly, because there isn't very much evidence. We have one population-based cohort from Canada that demonstrated an 8% increased risk of CVD in patients who had LTBI compared to those who didn't. And then there are 2 populations, observational studies, that showed that there was an increased odds of subclinical coronary artery disease in patients with LTBI compared to those without in Peru and Uganda. But again, together, these studies don't really give us very much in terms of causality, and they're really quite small. And the population-based study is, again, in a low burden for TB setting. So in summary, this has been just to bring everything together. We've got increasing evidence that CVD and its risk factors are associated with incident, prevalent TB disease, TB mortality, and all-cause TB mortality. Looking at etiology and pathology, we know that the most important manifestations are pericardial disease, but we've got some inkling that there may also be a relationship with atherosclerotic cardiovascular disease, but we really don't have enough pathological or mechanistic data to support that relationship. And in terms of LTBI and CVD, we need to do a lot more work to look at this relationship in more detail. So where that leaves us in terms of research gaps is that the burden of CVD remains poorly characterized, particularly in TB disease, but also in LTBI. And this is a problem because it's even more poorly characterized in the highest burden settings for TB. This really matters because we don't understand the etiological mechanisms, and they're probably vastly different to what we encounter in high-income settings that are low burden for TB. And this limits our evidence base for integrating care pathways for TB and CVD, as both burdens remain problematic in around the world. So I'm advocating for many more observational studies, mechanistic studies looking at advanced cardiac imaging studies and proteomics to really underpin this relationship better, and distill these all in implementation studies that might strategically think about AI-assisted bedside echocardiography and the use of biomarkers so that they're more applicable in resource-constricted settings with high TB prevalence. And finally, very briefly, this is my current study. So I've recruited patients cross-sectionally with a comparator population, 250 patients with pulmonary tuberculosis. And the headline result is that the prevalence of cardiac pathology so far is very similar to the Zambian study, about 40%. And this is against 11% in the comparator population. So at the moment, TB patients have 5-fold increased odds of cardiac pathology than those without in my cross-sectional study. I'm also going to follow these patients up over 6 months, and I've got some interesting early biomarker data around troponin and BNP and CRP. Troponin hasn't been useful, but BNP and CRP seems to be strongly associated with prevalent cardiac pathology.
Yes, so my name is Collins Timere. I'm happy to present my talk on financial impacts of tuberculosis. I think it's better that I start by giving a brief context in which TB treatment occurs so that we'll appreciate some of the financial impacts of TB. We probably all know that TB occurs in context of social and economic deprivation, and poor people are disproportionately affected, and they are likely to have little savings and unstable jobs or income. And in most cases, they depend on physical energy to earn their living. So much that when they are affected by TB, they usually pay out-of-pocket expenditure. And the out-of-pocket cost may be substantial to poor people because they've got little income. So let me just present a trajectory from onset of illness to completion of TB. So from the moment one develops TB symptoms up to the point where treatment starts, there are a series of events that patients have to undergo. For example, they might think that the illness is due to other causes, and they might seek health care from alternate service providers such as pharmacies and the traditional healers. In our setting, that's what we observed in one of our studies. So that delay from onset of symptoms to diagnosis, it results in some experiencing what is known as physical debility, and some might actually die. So there are a lot of costs that are incurred during this period, and some of them are direct medical costs related to chest radiographs and also consultations, because some visits in private healthcare providers. Then there are also direct non-medical costs related to transport and food, and income loss, which is due to inability to work and also reduced capacity to work because they depend on physical energy. So even by the time they start TB treatment, they still continue to incur costs related to food, transport, and in some cases, they might relocate in search of caregivers and also in search of family support. Even after completing TB treatment, people with TB continue to incur costs and they might continue to borrow and sell their assets in order to cope with the treatment. So in Zimbabwe, around 2018, we conducted what is known as a patient cost survey, and we observed that 80% of TB-affected households experience catastrophic costs in Zimbabwe. The global pooled average of catastrophic costs was around 43% against a target of 0% catastrophic costs. So catastrophic costs, these are total costs, which is a direct costs, medical and non-medical, plus indirect costs related to income loss divided by annual household income prior to TB. When those costs are at least 20%, when that fraction is at least 20%, we consider those to be catastrophic costs. And the major drivers of catastrophic costs are outside the healthcare system. So the financial impact is based on the work that we conducted in Zimbabwe, and those are some of the papers that informed the financial impacts, which are going to be described in this paper. So TB-related costs, they push households into poverty and financial catastrophes. And in most cases, the costs act as barriers to accessing TB services. For example, costs might hinder people from seeking healthcare early. They might delay health seeking, and they might not get enough money to pay for transport to get to healthcare services. So those costs are associated with up to 35% loss to follow up before diagnosis and even during treatment. And since TB mainly affects productive people around 25 to 44 years, it invariably leads to income loss for the household because household members earn a living collectively and individually. So they reduce the capacity, both reduce the capacity and also time spent during health seeking, they result in income loss for the households. So when the household has got reduced income loss, they might adopt harmful coping strategies like selling assets. And this affects household income both in the short term and in the long term. For example, some of the qualitative findings show that initially households might start by selling non-productive assets, but then might proceed to selling productive assets. As you can see, one of the participants sold a PA system, which was a productive asset. So even after completing TB treatment, these people might take a long time before they attain pre-TB treatment income levels. And also, as a result of reduced household income, they might also adopt coping strategies such as diverting money that was meant for children's education, and this affects even the education of children. Then other coping strategies such as reducing the number of meals leads to undernutrition in the household, and this increases vulnerability to TB, and also it might result in advanced TB disease. This might also result in TB-related death, and TB-related death affects both informal and formal education because mainly breadwinners are affected. So there is going to be socio-economic dislocation at household level, and also because breadwinners are probably reservoirs of knowledge and skills, that might affect even informal education. I pasted a table on some of the coping strategies. As you can see, we compared drug-resistant TB households, drug-sensitive TB, and non-TB affected households. And it's quite clear that TB affected households, they spent savings, they borrowed, and also they experienced income loss as compared to non-TB affected households. Then there's also this variable here on failure to repay loans. You can see there is high proportion among TB affected households. So sale of assets is a proxy for financial catastrophes, and it reduces productive capacity even when the person who was affected by the TB recovers. Then also failure to repay loans, it affects credit rating and access to interest-free loans. So this also affects even their social capital, which is very, very important for social support during TB treatment. Then we also observed in some of the qualitative papers that TB narrows job opportunities during and even after completing TB treatment. For example, if someone used to work in dust environment, after completing TB treatment, they're supposed to change livelihood strategies. So that is got a huge bearing on household income. We've got a lot of costs. For example, this man used to work as a DJ, but is no longer supposed to work in dust environment. Then it also, this lady was affected in so many ways. She was abandoned by her husband. We know we live in our patriarchal society. The husband are the main breadwinners. So it affected household income, and it also affected her job opportunities. Even during post-TB treatment, we also observed that households may continue to borrow and sell assets. It was also observed in other settings, like in India. And they continue to incur medical expenses. So it might be difficult for households to attain pre-TB income levels, and this renders households vulnerable to TB and other shocks. And I might hasten to say that TB does not affect households as an isolated shocks. TB affects household either concurrently or sequentially with other shocks. So it comes as an extra layer to the shocks that are prevailing within the living environment. Then I've talked about TB-related stigma and social exclusion, abandonment by spouses and family members. So it affects social capital and social support system, as well as participation in economic activities. So as a way forward, I think there is need for social protection because it tackles social marginalization and also exclusion so that people with TB actively participate in socioeconomic activities. And social protection can also be used to ensure that people with TB, they diversify their livelihood strategies, especially following TB treatment. This will enable them to start other business ventures so that they can improve their lives and they can attain in pre-TB treatment income levels. However, for that to be effective, social protection will need to be adequate. It will also need to be comprehensive because TB, the impacts of TB are multifaceted. It also needs to be timely and there must be sufficient coverage in terms of the proportion that actually receive social protection. Lastly, there is also a need for social protection to be adaptable so that when there is a covariate shock like TB, we can expand coverage to other population groups and we can also increase even the size of the displacements. Over. I think I'll stop for now.
Thank you very much, Collins. You were exactly on point. So great and superb presentations. Thank you very much. There are already a couple of comments and questions in the chat. If you want to answer some of them, but otherwise we will also come back to them after the next two presentations. So if you could stay online, that would be amazing. Thank you, Collins. If I now could hand over to Arjita to speak about TB and diabetes, which is obviously also very much interlinked.
All right, thank you so much, Katrina, for the introduction and worries about the time mix-up. Can anybody see my screen? Okay.
Yes, and you're in presenter mode. It's all good. Thank you.
Okay, perfect. All right, so my talk today is going to be about TB and diabetes and how this is going to be a threat to TB elimination. I am a postdoc at Stanford University School of Medicine. And yeah, let's get going. All right, as any other epidemiologist, I would like to start my talk by showing some maps and numbers to show where and how big the health problem really is. So these two figures here are showing how TB overlaps with diabetes, with the left panel showing the estimated incidence of TB and the right panel showing the global burden of diabetes. And as we can see here, the countries with the darker green color on the left panel indicating countries with a high TB incidence actually correspond to some reddish color on the right-hand side of the panel, which indicates a high burden of diabetes. And a couple of geographic hotspots that we can see here include Southeast Asia, Western Pacific, parts of Africa, and South American regions. And when we talk about the associations between TB and diabetes, it is always said that the directions of the association is two ways, meaning that diabetes could increase the risk of TB and TB could increase the risk of diabetes. But for the first direction, which is diabetes increases the risk of TB, a couple of published review papers out there have already established the biological pathways. And to put it simply, diabetes impairs innate and adaptive immune system, and the hyperglycemic conditions of diabetes patients could also impair macrophage and neutrophil function, and both of these together could increase the host susceptibility of to MTB infection. But what about the other direction, which is TB increases the risk of diabetes? And so we actually wrote a review paper on one of the possible biological pathways, which is through stress hyperglycemia. So in this paper, we highlighted how systematic inflammatory responses during an active TB episode could actually induce stress hyperglycemia, which could then increase the risk of later progressions of type 2 diabetes. All right, so in this figure, I am showing the natural history or progressions of TB disease and how diabetes could negatively impact TB and treatment outcomes. So for example, globally, it is estimated that 15 to 20% of global TB cases are now attributed to diabetes. And diabetes could also increase the risk of progression to active TB by 2-3 times. And in our review paper, we estimated that nearly 1 out of 4 TB-sick individuals receive diabetes diagnosis at TB treatment initiations. And in the next few slides, I'm going to focus my talk on how diabetes is actually associated with poor treatment outcomes. All right, so these two Kaplan-Meier curves here show that TB diabetes patients, whether they have drug-resistant TB or not, they required a longer time to achieve sputum culture conversion. And what this means is that TB diabetes patients may have a longer infectious period and more likely to transmit the disease to other people, especially if they are not being educated on coughing etiquette. And diabetes was also associated with poor treatment efficacy and TB treatment outcomes. So for instance, some studies actually showed that plasma concentrations of anti-TB drugs, including rifampicin and isoniazid, were actually lower among those with diabetes. And the fact that there might be some drug-drug interactions too, as rifampicin may alter glucose metabolisms. Diabetes was also shown to increase the risk of TB recurrence and treatment failure and development of MDR-TB, as well as deaths during TB treatment. And then a recent work that we published showed that the joint effect of diabetes and low BMI actually resulted in poor TB treatment outcomes, as shown in this Kaplan-Meier curve. So in this curve, we can see that among drug-resistant TB patients, the survival probability was actually lowest among those with diabetes and low BMI. So this work was actually led by a PhD student from Radboud University, Lara Fiken, who has been spending some of her time with us in Bandung since 2023. And while it is well established that diabetes is associated with poor TB treatment outcomes, critical gaps in knowledge remain persistent. So diabetes is often seen as just like a categorical status, that is whether you have it or not. So we don't know much about the role of effective diabetes treatment on reversing the associations between diabetes and poor TB treatment outcomes. And furthermore, since the majority of TB diabetes studies only include a single diabetes measurement, which is typically done at TB treatment initiation, we know so little about stress hyperglycemia as well as the benefit of measuring glucose level over time. We also don't know whether the magnitude of the associations between diabetes and tuberculosis is actually the same across different diabetes phenotypes. We are also seeing that the majority of TB diabetes research are actually based on the premise that diabetes increases the risk of TB. But what about other directions? Are TB survivors at elevated risk of developing diabetes? And if yes, through which biological pathways? And among individuals with TB diabetes, are they more likely to develop diabetes complications compared to diabetes-only patients? So all of these questions we have very limited knowledge about. And this figure is actually taken from a review paper that we published in 2018. And essentially here we can see how that during the early phase of TB, individuals may experience some acute inflammation and stress hyperglycemia because the bacteria are not well controlled by anti-TB drugs yet. And we postulated that a substantial proportion of patients may revert their metabolic profile to normal after the bacteria is being controlled with anti-TB drugs. But some may have persistent hyperglycemia or dysglycemia, which could then contribute to the later progressions of some cardiometabolic diseases, including diabetes. So we start seeing some signals in human population study. For example, a retrospective cohort study that we did using the Taiwanese health insurance claim data suggested that diabetes incidence was actually higher among TB survivors. But in this study, we did not have any comparison group. We just happened to have access to TB survivors data. And so we just compared our estimated rates, incidence rates of diabetes to the rates reported among the general populations reported by other study. Another interesting finding from a post-TB cohort of 120 individuals that we enrolled after a successful TB treatment in the country of Georgia. So in this cohort, nearly half of the study participants actually gained at least 5% of their BMI during TB treatment. But in this study, we found that weight gain of at least 5% during TB treatment increases the risk of post-TB metabolic syndrome with an odds ratio of 2.4. And so as gaining weight is actually desirable during TB treatment, this study finding challenged that notions by basically highlighting the need that there is a need to maintain a healthy weight gain during and after TB treatment. So the goal should not just be gaining weight during TB treatment, but like maintaining healthy weight gain during and after TB treatment. All right, I kept talking about the associations between TB and diabetes, but what people often forget is the fact that diabetes is also associated with latent TB infection, as shown in a systematic review and meta-analysis by Liu and colleagues here, which reported a pool odds ratio of 1.2. And interestingly, another recent work using data from the US Fed also suggested that diabetes incidence rate was actually higher among individuals with latent TB infections compared to those without LTBI. All right, so for the public health implications regarding the bidirectional associations between TB and diabetes, we certainly need an integrated disease management guideline, which we do now thanks to our colleagues. But I'm certain that the implementations of several key recommendations, including bidirectional screenings, integrated TB diabetes care, as well as patient-centered care, are still very limited, especially in resource-limited settings. We also need more research on optimal regimens for both diseases, especially considering the different phenotypes of both TB and diabetes. And just to conclude, I just wanted to make a case why TB and diabetes comorbidity could be one of the major threat to the global TB elimination milestone. So first and foremost, we are seeing a constant rise in diabetes prevalence, especially in TB endemic countries. And with with diabetes being associated with not only TB, but also latent TB infection, which is a much larger population. We're talking about a quarter of global population here. So this dual epidemic will not be eliminated anytime soon. And even if we just focus on TB, we have an estimated of 155 billion TB survivors, and an additional 9 million more are at risk of developing metabolic diseases at some point in their life. So this will translate to a massive strain on healthcare system. And I'm happy to take question if there's any. Thank you.
Thank you very much, Ajita. Again, completely on time. You're all such easy to chair people. So thank you very much. There are already kind of questions in the chat. We will take questions after the last speaker. And I think we will have enough time to take some of the very interesting questions. But if you want to answer the questions in the chat in the meantime by writing, that would be also amazing. So thank you very much. And your point on the other direction of TB and diabetes is very well taken. I mean, somebody at, I think it was at last year's TB conference, mentioned in one of the sessions, maybe there's something a bit similar to gestational diabetes, like TB diabetes. So I think that's really a very interesting kind of way to think through it. Thank you very much. The next speaker is Andrea Racho. I think Andrea is also online. Andrea, the floor is yours if you would want to start sharing your slides.
Yeah, so thank you very much for the invitation to give this talk here in that symposium. It's a great honor to me. So I'm Andrea Racho, and I'm working at the Institute of Infectious Diseases and Tropical Medicine at the LMU in Munich. So let me move this away a bit. Okay. So to show you the relevance of my topic today, I would like to start with this graph from a modeling study by Dodd et al. I think most of you may know this. So according to the investigators who modeled the number of TB survivors, there were 155 million TB survivors alive in 2020. And Agita just mentioned that another 10 million new patients is added to this number. So roughly, we would have one TB survivor among 50 people globally. And however, the majority of these survivors lives in low and middle income countries, and also more of them are male and females. So this is a huge number of people that are potentially at an increased risk of higher mortality. And this was shown for the first time by this systematic review by Romanovsky et al. They included in a meta-analysis 10 studies from 5 WHO regions and showed that the standardized mortality risk is increased in survivors, in TB survivors. That was the case in 9 studies, even from studies from high-income countries. And the combined estimate was 2.9, and quite robust here on the figure. The main cause of death in the studies that assessed this was cardiovascular disease. However, I would like to mention another study by Ranzani et al. That was published 1 year after this review, that was conducted in a huge population where the main cause of excess death was respiratory diseases next to infectious diseases. In addition to mortality, also morbidity is increased after TB, and that can be shown, for instance, and healthcare utilization data. And this is a study that shows the excess in healthcare use of 1,200 foreign-born TB patients that were treated in Canada. And you can see here the relative increase in hospital submissions compared to the hospitalization rate that would have our TB. This group was 6% in the first year after the post-TB period. And that decreased then to the pre-TB level. However, when you look at the increase in the outpatient encounters, that was 34%, and that remained high throughout a 5-year follow-up period, and that correlates to 12 access outpatient encounters in 5 years among this group. And interestingly, apart from other causes of healthcare encounters, the relative increase of consultations due to respiratory conditions remained throughout the 5-year follow-up period. So there is a high burden of respiratory diseases post-TB and post-TB lung disease, abbreviated by PTLD. Nowadays, one of the best recognized long-term TB consequences. Post-TB lung disease was coined by the delegates of the first International Post-TB Symposium held in Stellenbosch in 2019. And this is just a screenshot of the web page of the symposium, which is still active and also holds many interesting information on that topic. Might be able to access this from time to time. So, and the first symposium also came up with the minimal case definition for PTLD, and you can see this here. So this is a very broad definition, but it allows for coexistence of pre-existing diseases that may be present in TB patients before they develop TB, such as COPD, but also other exposure to other risk factors like indoor air pollution, for instance. But it also allows for the detection of asymptomatic and preclinical disease stages, which is important. And I will speak to this more later. So what are the common clinical findings in TB patients? So here there are 3 review and systematic reviews analysis that were published in the past years. There are 1 or 2 more now summarizing the existent evidence on the respiratory abnormalities that can be found in TB patients. So the estimates in all these reviews were quite similar, comparable, which I think was good. So in summary, there were 60 to 70% of the patients in the studies that showed radiologic abnormalities. 40% roughly had persistent respiratory symptoms like cough and dyspnea, and 50% had abnormal spirometry. So the problem with the majority of the studies that were included in these reviews, apart from methodological challenges, was that they were cross-sectional and often analyzed only one health outcome. Yeah? So for instance, there was airways obstruction assessed in studies that used spirometry. So that means our understanding of the evolution of these pathologies and symptoms over time, and also the outcomes of patients having these symptoms, is very limited. And equally, our understanding on how the different pathologies are combined or correlated with each other in the different patients. So in the sense that they can use specific phenotype is also very limited. However, this is needed to develop diagnostic approaches, therapeutic approaches. I would like to give more details on clinical aspects of patients with PTLD, and I chose this study. This is a very recent study in 48 patients from South Africa. The investigators really looked at a battery of respiratory assessments, also very advanced tests like PET-CT scan. And here you can see the PET-CT scan from a patient with severe TB-associated lung damage. In fact, all patients in the study showed abnormalities on CT after TB, and small nodules were most common, followed by fibrotic scarring, cavitation, bronchiectasis, and bulla. About 46% of the patients had abnormal spirometry results, and you can see here in that plot highlighted with the yellow circles that the severity of the pathologies on imaging correlated with the severity of lung impairment. So that means the more advanced fibrosis was, the bigger the cavity volumes were, the more severely impaired the lung functions were, the different parameters were. Interestingly, a set of parameters, tolerance, and like standard walk test or quality of life did not correlate with respiratory or with the pathologies seen or the severity of pathology seen on imaging. But there was some correlation between exercise testing and quality of life with the level of inflammation in PET scan. And overall, and that was also interesting, only a small proportion of patients complained of symptoms or reduced exercise tolerance, although many of them had advanced disease. And what the study also shows is that pathologies they are developing in parallel. So the parenchyma is infected like the air, but also the vessels, and this is translated in different impairments of different respiratory parameters, and this develops in parallel in the same patient and not separated like some patients developing fibrosis, others obstructive disease. And this is especially true in patients with advanced lung pathologies. I skip that due to the sake of time. I want to say quickly on the pathogenesis. So you could see that PTLD is a very heterogeneous disease of diverse pathology seen in the same patient, but also between patients. And one of the reasons is that many different pathways seem to be involved in the development of PTLD, inflammatory pathways, like also pathways we need for tissue repair and tissue regeneration. This is another figure also from the study by Webb et al. Showing the different inflammatory cytokines in blood. For inflammatory cytokines, I already highlighted here some, but also markers of tissue remodeling like MMPs or growth factors correlated with measures of inflammation, severity of pathologies on imaging, and spirometry impairment. And what is also important to say is that this is a post-TB cohort. So obviously, the markers remain increased, indicating that inflammation is continuing in the patients, maybe drivers of the secondary complications like exacerbations, development of pulmonary hypertension. I will not speak more about due to the sake of time. And the notion that inflammation is ongoing is also supported by Steve Tumor et al. And I want to highlight population 1 here, which is a population that had treatment of more than a year ago. And also in these patients, the serum markers, like inflammatory cytokines, were increased, comparable to those levels of a population 2 here. So despite of the relevance of that problem, the morbidity and mortality we see in these patients, there's no guidelines on PTLD health.
Okay, my first instinct is always so that it's my internet which is the problem, but I do think that Andrea's internet was maybe not so stable. Let's give her just a moment to come back. She's almost on the minute, but while we wait for her to come back, I think there are already a lot of questions in the chat, and maybe Ajita, we could ask you the first question while we wait for Andrea. I think there was a comment from Gail about 5% weight gain in the rations trial, which was life-saving. And how does that, I mean, also the kind of a nutrition composition compare with the Georgia data set? Maybe you could comment on that.
Yeah, sure. I think the 5% is definitely something that we came up with after seeing the distributions of the weight gain in our study populations, right? And so I think I mean, there's definitely like differences in our Georgian TB populations with, let's say, India and Indonesia, for example. I think one of our study radiologists is actually commenting how very preserved people's lungs is in Georgia, to the point that he was asking one of us, like, are you sure that they have TB? And so that really kind of like maybe strike the difference, like that the TB population in Georgia might be completely different with, you know, TB populations in other part of the world. But I do agree with whatever Gail was saying, that, you know, it's not just like the gaining that is the main thing that we have to worry about. Is like, what is the good range to gain your weight during TB treatment. And so in our study, I think I put it in the chat that we only use BMI, but we know that BMI is not a very good proxy for measuring somebody's nutritional status. And so definitely more studies that include more comprehensive measures on people's nutritional status would be needed. And I think we also have to think about like where people actually started, like during their TB treatment. Are they severely underweight or no? If yes, then, you know, maybe the at least 5% weight gain is probably more desired for this subgroup compared to people who started off maybe like in the upper normal range, or even like overweight or obese. So yeah, I think that's my take.
Thank you, Ajita. And I also wonder, you know, there's weight gain is not the same as weight gain. If you gain muscle, that's obviously good. If you just gain fat, that doesn't really help that much. So it's really about which component. And a lot of the cachexia is driven by losing muscle. So even in people who might have been overweight, if they lose considerable weight, it might have been the muscle which is lost and never actually recuperated. That's great. I mean, again, I don't think Andrea is back on, but maybe I could hand over to Krista, and you could actually ask the question you have asked to Collins about social protection.
Hi, everybody. Good evening from here. I've been enjoying our conversation with Collins about the role of TB sensitive versus TB specific support in the context of costs. So, Colin, you've provided a beautiful answer, but perhaps you'd like to share that with the larger group.
Yes, I think I shared it with the larger group. So in Zimbabwe, we've got the Minister of Public Service, Labor and Social Welfare. They manage different social protection schemes like the disability grants, assisted medical treatment order for those who are hospitalized. However, TB is not one of the eligibility criteria for inclusion into those schemes. So I think going forward, there's need for inter-ministerial collaborations between the Minister of Health and the Minister of Public Service, Labor and Social Welfare, so that those policies like the disability grants can be tweaked so that they become TB inclusive, so that TB becomes one of the eligibility criteria.
Thank you very much, Collins. Superb. And also you have, I think, put in some some of your publications in response to one of the questions. There is a question about, again, body composition. So I think there was a question from Gail about body impedance. Is that a measure of muscle fat ratio? I think, Ajita, if you could speak to that. No problem, Andrea. We are all sympathetic with internet problems, so don't worry about that. Ajita, over to you.
Yeah, so I think with bioimpedance, like you also get the fat ratio and the distributions. And so this is actually like a much reliable measures compared to just BMI. And I think a lot of people also use like hip waist ratio and stuff like that. And so there's like a lot of like measures out there that we could use, maybe more reliable compared to just BMI alone. But yeah, essentially with body impedance, it's also like not invasive. You just need to hold on something, and then step on a scale, and then they will calculate your body weight, mass, fat ratio, muscle ratio for you.
Thank you very much, Ajita. Gail, could I ask you, I know it's way back in the the kind of WhatsApp, not WhatsApp, in the chat. Can I ask you to ask the question about right heart versus left heart, so that Marcello could give us a bit of process his thoughts about that. Over to you.
I think maybe this is a question both for Andrea as well as for Marcello. I was just thinking as you were presenting that, you know, there's a lot of similarities in the architectural destruction that happens in the lung. You get lung fibrosis, and I know the data from in post-TB lung disease is that people develop both restrictive as well as obstructive pictures in their lungs. And then I think about some of the patients that I've seen, and sometimes they have such progressed lung disease that they end up with right heart failure. And I wondered, because I've never seen anything in the literature with regards to this, is if there are studies that have examined the presence of right heart failure in the setting of people who have very advanced TB disease of their lungs and that architectural damage in their lungs.
Marcello, and then maybe Andrea. Marcello, over to you.
Yep. Okay, great. Thanks for the question. No, indeed, it's true. I should have prefaced that I focused everything on left-sided heart disease, and I think that's because, in the context of CVD epidemiology and public health, that's where the biggest interventions are for cardiac remodeling that might have long-term implications in terms of mortality and indeed the health of a population. There's a lot of really interesting work from Brian Allwood in South Africa, who looked a lot at pulmonary hypertension in TB patients, both post-TB and also looking at incident pulmonary hypertension, or certainly prevalent pulmonary hypertension in TB populations in South Africa, and I think his colleague Lau, L-O-U-W. I can put the links in the chat. And then there was a recent systematic review that looked at right-sided heart disease and pulmonary hypertension specifically in TB populations, and there's certainly a very clear relationship there, and a lot of it has to do with well, we think destroyed architecture as well as possibly the inflammatory burden associated with TB disease. But again, it's not been characterized particularly well yet. I think from my own personal experience as an infectious disease physician rather than a cardiologist or a respiratory physician, there's also this, cardiologists don't really look very much at right-sided heart disease because they can't do very much about it and sort of leave it to respiratory physicians to manage and deal with. And I think that's also where we've had a bit of a disjointed research base between right and left-sided heart disease. I hope that sort of answers your question.
Yeah, and right-sided heart disease, right heart function is just harder to measure. It's
exactly,
you know,
yeah, also, yeah. But interestingly, a lot of the echoes that I've been doing, there is evidence of right-sided heart disease and some early pulmonary hypertension. So I think it's likely to become a huge undiagnosed burden, particularly in the post-TB population.
Andrea,
Marcella.
I wonder if you could add to
Yeah.
that.
Yeah, there is not much to be added. So Marcello already mentioned the work of Brian Allwood, and I think he is I think he was co-authoring the meta-analysis you mentioned, Marcello, and also the study. And yeah, and I agree there might be the pathomechanism is not well understood. That might be like the hypoxia-driven pathway, but also direct damage of the vessels that result in pulmonary hypertension. Yeah, so there's no more things to be added.
Thank you,
Oh, sorry.
Gail.
Yeah, I just wanted to ask Andrea a follow-on question, which I was going to post on Andrea anyway. There's, Bob Wallace has shown that some host-directed therapies have some benefit in the metrics of specifically improving spirometry in patients with pulmonary TB. And one of the drugs, at least, was a PDE4, so prostaglandin 4 inhibitor. And it came to mind because we're looking at those, patients with post-TB lung disease clearly have sustained inflammatory processes that are ongoing. And I just wondered if you could comment your thoughts on the utility potentially of using host-directed therapies as a means of trying to prevent people from developing post-TB lung disease.
Yes, so I do not know the details of Bob Wallace data of the metformin and phosphodiesterase, the trial where he used also the phosphodiesterase inhibitor. Actually, both trials are still ongoing, or it's one trial where he assess both phosphodiesterase inhibitors and metformin in the same study. I think the study is still following up the patients, and I do not know any data of this. But he had a pilot study done on that, and I was not involved in that study, but it seems that in terms of spirometry, there was an improvement. What I know more is the data on N-acetylcysteine, because also in TB sequel we generated the first data of the pilot study on the effect of N-acetylcysteine on lung function, and we now do a confirmatory trial. And N-acetylcysteine is an antioxidant. It's also used in other chronic lung diseases and COPD. It's not only for the mucolytic action, but really also for the action on reducing oxidative stress. How this does it and why it works in some patients in COPD and not in others, it's not clear. So what we see in TB patients is that those with most impaired lung function, with most advanced pathologies on chest X-ray, there is a significant improvement in lung function, so superior to the improvement of patients that are not treated with NAC, and that reaches the level of clinical meaningful difference, which is also not clear for PTLD patients how much that is, whether it's 80 milliliter or 130 milliliter of FEV1, but we saw a difference of roughly 130 milliliter. So so we need to wait for the results. Like there's also other trials. So on doxycycline, which is a metalloproteinase inhibitor, and there were also promising data. I think from a study in Singapore, and I know that a trial is currently ongoing. So so there are some pathways that might be promising targets for host-directed therapies, but I think the challenge will be to identify the patients that benefit from the different therapies, and we need to better understand. That's the problem also, to find biomarkers for these pathways in order to identify the patients that will benefit most. And I did mention that in the talk, but I was not aware that I'm offline, that it's also unclear what the outcome measures are that should be assessed, to monitor the treatment effects. And is it FEV1 like for COPD? But even in the COPD field, there's this question, yeah, so people go now for exacerbations, quality of life measures, and yeah, we do not know this yet for PTLD.
Yeah, what makes meaningful change? Thank you so much. Thank you.
Thank you very much. Obviously, a very interesting discussion, and we could go on and on for a long time. I'm aware that in 20 past, we will start a new session. So I want to give people a chance to actually go and have a little bio break, and handing over to Celso Cosa from Mozambique for chairing the next session. I just want to plug one thought, and Marcello, maybe you can answer in the chat about that. With an aging TB epidemic, i.e. especially in Africa, where we are now seeing people who are more in the age range of late 30s, beginning of the 40s, which we might not think is old, but much older than people used to be. How does the kind of cardiovascular problem affect that presentation, but also potentially how we would need to think about caring for these people? If you could answer that in the chat, that would be great. And I'm handing back to you, Michaela, or over to Celso, and we will start in 2 minutes with the next session.
Hello, everyone. Good morning again. My name is Celso Cosa. I'm a researcher and clinician working in Mozambique with National Institute of Health. I want to welcome you to our session on integrated TB screening and care. This block connects the today's Syndemic insights with the first a survivor testimony, and then 2 presentations. So I would like to start now asking Edson Marambili to lead the video that will precede the 2 presentations. Edson, the floor is yours.
So I'm here with Joanna Casirori. My name is Edson Marambire from the Health Research Unity at the Biomedical Research and Training Institute, and I lead the TB research portfolio here at the Health Research Unity. And we also have a TB community advisory body in which Joanna Casirori is a very important member of that body. And in the this TB community advisory body is very instrumental in our TB researches from inception, that is grant writing, implementation of these studies, even up to publications. And I'm happy to introduce one of the members of this CAB, who is also a TB survivor. And I think Joanna will be able to introduce herself more properly. To you, Joanna. Can you introduce yourself first before we get into the questions?
Okay, my name is Joanna Casirori. I'm a TB survivor. I had pulmonary TB in 2004.
Okay. Is that all?
And I'm also living with HIV. I'm also living with blood pressure. I'm also living with diabetes.
Okay. Okay, that's fine. Thank you, Joanna, for the introduction. And also, you maybe left that professionally. You are also an educator, is it?
Yes, I'm also a high school teacher.
Okay, thank you. Okay, so we move on to the group here just want to understand your TB story and what impact did undernutrition, financial hardship, HIV, diabetes play in your TB journey? And as someone who previously had TB and who works with people who have TB, what pressures of life do you find TB doctors and nurses do not understand or cannot help? And what would you, what kind of support would you advocate to be given to these people during TB treatment or life afterwards, that is life after TB treatment. And lastly, how can TB programs can better support the whole person, including other needs, rather than just TB?
Yes, and so there's a lot that happens when you've got TB. You are affected psychologically, you are affected physically, you are also affected economically. My journey was a difficult one because I deal with school children. The community also has a lot of stigma and discrimination when you've got TB. And most breadwinners who have TB lose their jobs in the process of getting treatment because you have to go to the clinic most of the times and you might not be able to go to work every day. Some people even lose their marriages in the process because remember, TB is associated with being promiscuous or even associated with HIV and AIDS. Mine was with HIV and AIDS. I had HIV and TB at the same time, but my understanding and everybody's understanding is that you necessarily do not have to have HIV. You can sometimes have TB on its own. So even the nutritional aspect, many people do not recover as quickly as they should because of lack of balanced meals. Sometimes a person with TB can go for a day with only one meal, which we call 0-1-0, which means you choose to have maybe breakfast and then you can have supper, which is the usual starch in Zimbabwe is just sadza. That's why maybe many people with TB develop diabetes as well, because you'll be just eating a whole lot of carbohydrates and not balancing with starch and vegetables. The TB journey is difficult when you don't have money. The TB journey is difficult. When you go to the clinic, I think there is need for a person with TB to be also checked for other diseases, checked for things like BP, diabetes, and other chronic diseases, so that a person is holistically treated, not leaving other things behind. Also, a person with TB needs maybe to be economically helped. For example, if they get maybe even chickens, or they get nutritional gardens, or they get some form of money so that they can start small businesses, because people with TB often lose their jobs in the process of getting treatment. And also maybe there is need for more educational things at clinics so that the TB survivors, or even those that are being treated, can have more information on the disease and how they can survive. I think there is need even for educational talks at the clinics, and also there is need for the nurses to have answers to the questions that we have. For example, when I was taking my TB treatment, my skin grew darker. I could not even understand why my skin was getting dark. When I asked at the clinic, they just said, we don't know. Just take your medicines, and as long as you are alive, don't worry about the other things that are happening to you. And even my body structure changed. I had a very big upper body and very thin legs. And that again could not be explained by the nurses and doctors that were assisting me. So all these things, they make you lose even your self-esteem. And there are signs that people always associate with TB. So the discrimination comes into hand because people will see you with a dark skin, people will see that your body structure is changed, and they will have questions.
Okay. Thank you, Joanna. I know you have a whole book of story to talk about, but you managed very well to summarize it in 5 minutes time. Thank you very much. To you, also.
Thank you, Joanna, and thank you, Edson. I think there's one comment and one question for Joanna. Maybe we can reply on the chat. In the interest of time, we will now move to two presentations. Each presentation will have 13 minutes. Please make sure you will post your questions in the chat, and those will be discussed during the panel at the end. The first presentation will be given by Dr. Anastasia Koch. Anastasia is a co-director of the WOSA and a lecturer at the UCT. She works at the interface of youth advocacy, skills development, public engagement, translating complex science and social determinants into action for TB comorbidity. Anastasia, I think we can see you and we can see your slides. The floor is yours. Thank you.
Hi, everyone. Thank you for including me and introducing me. It's really interesting. I've worked in the TB field for quite a long time, and there's a bunch of people that I don't recognize names on the call. In fact, I recognize very few names, which is really amazing. So I really appreciate the opportunity to interact with a new network of people that are working on a really important disease. So I'm going to try and stick to time and just tell you a little bit about my work. So I am Dr. Anastasia Koch. I'm the co-director of EWOSA. I'm actually trained as a molecular microbacteriologist. So I did my PhD on drug-resistant TB at the University of Cape Town, where I still have an honorary lecturer position. And I'm a fellow at the Institute of Infectious Disease and Molecular Medicine. So before I show you an example of our work, I'm just going to tell you a little bit about what we do. So EWOSA is an organization that was actually incubated within the Institute of Infectious Disease and Molecular Medicine at the University of Cape Town. The community and public engagement work developed very organically out of a desire from postgrad students to engage with people who were affected by TB. Between 2013 and 2019, we implemented multiple informal and distinct projects, all with a common thread to engage people with the biomedicine of TB, but to also develop a platform where we could encourage storytelling about the lived experience of TB and open up a discussion around that. In 2020, in a big shift for us, we were awarded a discretionary award in public engagement from the Wellcome Trust, and that allowed our collective to move from being a small group based within UCT to becoming an independent not-for-profit organization. So what do we actually do? We work at the intersection of public engagement, youth advocacy, science communication, and skills development with the aim to bring together the biomedicine of disease with its social impact. And I'm going to give you an example of some of our programs now. Really importantly, we see our participants as active partners. We aim to facilitate access to accurate information. We really want to ignite conversation and dialogue around diseases of relevance, including TB. That's where the work started. We want to tell storytelling. We want to develop storytelling around health and disease in a contextually relevant way, and really importantly, to develop capacity in community and public engagement and in the production of health-related media in our local context. Over the longer term, what we hope this will do is to encourage positive health-seeking behavior, engender trust in health research and health interventions, and decrease stigma around diseases of relevance. I am often the person doing the presentation, so I find it really important to put up a slide of our small team because all of the work is a real team effort, and also to make the point that we are a team that is quite interdisciplinary. So the co-director and co-founder of EWOSA is a visual artist. And then we have anthropologists and other scientists that are part of our core team. And also to acknowledge postgrads and postdocs that volunteer of their time to facilitate a lot of our workshops. And then also just to thank our partners, funders, and support networks. Our offices are based in the SCB Vana Center in Khayelitsha in Cape Town. For people who don't know Khayelitsha, it's a township 30 kilometers from the center of Cape Town, and it's a place that has some of the highest rates of TB in the world. Many of you probably know this, but TB is a disease of inequality. South Africa's got the highest rates of inequality in the world, and so the burden of TB disease is different depending on where you are in Cape Town. And I get the sense from many of the sessions that people already know that, but just to highlight that. When we moved to these offices in the center of Khayelitsha, it allowed us to scale our programs and become much closer to the population that we serve. So we're in the center of Khayelitsha and run a lot of programs with youth in the area. So I've put this slide up. These are our sort of core focus areas. They could be considered departments, but we're not a big enough organization to really have departments. So we all work on everything. I'll give you a brief introduction about all of these programs, and then I'll show you an example of one of the programs we run. So Learner Dockies is our oldest program, and in this program, we bring young people into the labs and expose them to biomedical research through a series of workshops. And really importantly, we are focused on engaging people with biomedical research rather than health information, because we felt we had a niche there where there are lots of wonderful organizations that do health information dissemination. As part of this program, once young people have learned about what TB is from a biomedical perspective, we provide the skills, equipment, and guidance for young people to make films about how TB is affecting their lives from an emotional and community perspective. And I'm going to show you one of those films, hopefully. To extend our reach to young people, we developed a program called Ewoza Youth, and this is all about dissemination of accurate information, but also really importantly, dialogue. So this is a Saturday workshop program where we engage 50 to 70 young people around a range of health topics. So we do TB, but we've extended to HIV, sexual health, cancer, climate change and health, and mental health. And here we have both informational presentation, but also small group work so young people can discuss these diseases. We've got to focus on engaged scholarship, so we try as far as possible to generate new academic knowledge around public and community engagement. We developed a science communication arm really during COVID because we realized we were making lots of films around the impacts of COVID on people's lives, but there was a scope to put accurate information out there. So this really is in terms of presentations and animations about how certain diseases work. Our internal team also produces their own documentaries independently, and this has a much more social justice focus. And then we've recently completed a project with the Wellcome Trust Photography Prize, where we did a project alongside the prize winners, where we facilitated storytelling through photography amongst a group of learners around health and disease, and their photographic projects were exhibited in London, which I think is a huge achievement for the learners. Okay, so I'm just going to explain to you how Learner Dockies works so you get a flavor for the work. And basically, it starts with a set of science workshops, which are held at the Institute of Infectious Disease and Molecular Medicine. So young people from Khayelitsha go into the labs and learn about what research is. We do topics like what is TB from a biomedical perspective, TB transmission, and the learners get talks from experts and also do hands-on experimentation to understand these concepts. After science workshops, we move into a media production phase where young people are trained in storytelling, the ethics of making films and getting consent, and also learn to use industry-level filmmaking equipment, and then go into the communities and collect stories about experiences of TB and other diseases. And what I've really appreciated from the discussion that's happened here so far, at the symposium, and what I can see from the program, is there's a real appreciation that TB doesn't exist in isolation. And so while the learners will go out and collect stories with TB as a starting point, often other issues come up, like social challenges or other diseases. And really importantly, we also train learners and guide learners in editing of their films. And this is really important to us even though it's difficult, but it allows the learners to retain editorial control around how the story is told. So it's not our stories. This is really storytelling from within the community. We've recently extended our work, and this is the film that I was going to say. So Khayelitsha is a peri-urban area in Cape Town, but we've recently extended the work into a rural area of the Eastern Cape, which is another province in South Africa. I wanted to highlight this because often a lot of our work is focused, at least in my context, is often this kind of work is focused in urban areas, and I think there's a real need to extend our engagement work and our research and health interventions into rural areas where healthcare access is very challenging. So we did a pilot last year with another NPO called the Bulungula Incubator. This area is very, very rural. There's no hospitals. It takes 3 hours on a very bumpy road to reach any hospitals. The Bulungula Incubator built a health point that is staffed by nurses, but otherwise healthcare access is very difficult to access. And we did the same. It was a Dockies program and science engagement with a group of learners in this rural area. The 10-day program allowed 4 films to be made, and I'm going to show you one of those. And we had a community screening at the end of the program. So I think I've still got a bit of time. I haven't actually checked, but I thought I can show you one of the film products that came out of this rural project. What I wanted to highlight before I show you the film is really that the story is truly from the community and was made by some of the learners that you see in this image. And I've chosen to show you this film because it touches on other diseases that are not TB, but I think shows how these challenges are very much integrated, which I think fitted with the focus area of this symposium. So I hope the film translates online. I'm gonna go over and Dr. Khoza, if I've gone over time, please feel free to stop me and I can stop the film and suggest that people watch it online.
Okay, thank you.
Gauteng ndaye ndadumba ibele ndadumba kakhulu ibele lam laqala ngoqaqamba then lagqibela ngodumba. Isabe lidumbile ndayakhe ekliniki wathi ugqirha lo mntu uthi wathi mama ungedithethi kusekliniki ematsirekane ukwathuna nto ngokedithethi walapha emadwaleni uthi ke ukuba kuthuna ntoni. So uthi ke wena hayi kwakuthiwe nephakuva uthi ugqirha mama sisukuxelele uba ngaba umama unantoni. Ithi mna hayi kamxelele athi yena umama unekhensa. Wazothi ke ngoku lo gqirha wandithumela kwisibhedlele kuthiwa iKoromane. Xa ndifika eKoromane bafika bathi bona bazondenza i-operation. Ndahamba ndaphindela endlini then ndazobuya after 3 days. Then ke ngoku bazondenza i-operation bakhupha into eround encinci. Xa beyisika ingathi zeke ligazi elimnyama eliqokeleleneyo. Then banikeza ke ngoku izipray zobana ndifaka kule ndawo because yayingeyo ndawo enkulu. Kwathiwa phaya akazonaliswa ngenxa ntoba le nto ayinaniwe kuzokunikwa nje izinto zokuthuthisa sabuye ke sahlala. 2018 ndagula angathi zeke ndiphathe sisisu ndahamba ndaya ngasesibhedlele eNelson Mandela ndabe ndisemthatha ke ngoko eNelson Mandela bathi akho nto bayibonayo. Ndaphindela endlini ndahlala ndiphathekile heyi kubuhlungu and ke ngoku into eyenzekayo njengoko ndilunywa ndiyahambisa and ndiyaphela apha esiqwini and ndatshintsha kwa ikhala yam amnyama. Ndahlala kunjalo ndiqonda heyi ayandiyazi uba kwenzeka ntoni and iipilisi endizinikayo ndiyazitya Then ndazohamba ke ngoku ndasuka emadwaleni ndabe apho ndiphelelwa ngamandla. Xa ndifika emadwaleni bathi bona ndine-TB yamathumbu. Bathi ekuhambeni kwemini ndini ukubetha koo-10 hayi yavuthwa into ndawa phantsi. Hayi ke ndaqabuka ngoku sendisiwe esibhedlele emadwaleni. Hayi kwathiwa hayi sestroke ke sendibambileyo kuthiwa emadwaleni. Ya hayi ke ndagqithiswa emadwaleni ndasuka eMthatha eMandela. Kulapho ke ngoku ndawufumana khona uncedo khona. Ndagqibela ke benditofa apha engalweni bendincokolisa. Emveni koko ndazokuthuka ke ngoku ndothuka sekungqalwe ii-gods apha ezimpumlweni zam. Xa ndibuza uba kwenzeke ntoni bathi bona laa nyama ibikhulile indivalile uba ndingaphefumli ngoba kwakusekhona inyama esayivele kule ndawo epinki ndingasakwazi ukuphefumla. Bathi ke ukubona kusikwe yona oku baze ndikwazi into yoba ndikwazi ukuphefumla. Ndahlala kunjalo ke ngoku bandikhupha ndakhutshwa ke ngoku esibhedlele iNelson Mandela ndakhutshwa kusithiwa ndinekhensa eyesiqini. Apha emathatheni ibindiqala kodwa ke abaqondi into yoba ngoku ndingazosebenzisa ikhimo, abaqondi uba inoba inokwanda inophinda okanye iphinde. Kwala ke emveni kweveki eziyi-4 ndala ekuseni xa ndivuka ekhaya xa ndiba ngathi iinwele zam azikho kule ndawo. Xa ndithi ziyazisukela nje kahle ngesandla sam kuthi krumkrumkrum ziyazisukela nje lula. Nda-understand into yobana ke hayi ke means ikhimo ilapha kum emzimbeni ke ngoku iyasebenza. Ngoba kwatsho into yoba xa isebenza uqala kwayo ukusebenza uzobona ngale nto nangalena nangalena. Ndabona kuqala ngokusuka kwenwele ndabona nokutshintsha kweskin esi sam uba ngoku ikhona apha emzimbeni wam. Iminyaka ide yam emini iphele ngqungqi phantsi kwathi kwesti.
Sorry, Dr. Koza, I've just seen that you've requested that we finish the video online, as there might be a time challenge. So just to say thank you very much, and I'll stop sharing now.
Okay, Tasha, if you allow me, thank you so much. Superb work. You have many comments and questions in the chat. We'll bring those to the panel after the next presentation. Our next speaker is Dr. Michaela Coleman. I don't think she needs introductions, but I will try my best. So Michaela is associated with the LMU, but also with Sydney Infectious Disease Institute. She works on TB and leprosy elimination across the Pacific and Southern Africa, with the focus on policy and climate sports settings. Her talk, she will provide lessons from Pacific leaders on integrated screening at the co-face of climate change. Michaela, over to you. Thank you.
Thank you so much, Celso, and thank you to all the amazing speakers on today. It's a real honor to actually share the political perspectives from leaders in the Pacific. I don't think it's a voice that we hear much, and this work was completed when I was at the London School of Hygiene and Tropical Medicine and is funded by a Rotary Global Scholarship. So the Pacific Islands are often a part of the world that are quite overlooked. They're a collection of very small islands. Most countries have multiple islands. It may take 2 days by boat or 4 hours by plane to travel within the country from island to island. And these are very brave countries that practice their unique heritage at the coalface of climate change. So in the words of William Shakespeare, though they are small, they are fierce. And there's also a lot of tuberculosis, unfortunately, in this region. So if we look at the global TB incidence, 8 countries have a TB incidence higher than 50 per 100,000, and 2 of these are in the top 10 globally. There's also a triangulation of these diseases with rising rates of comorbidities. You can see that diabetes and TB are the main comorbidity in the Western Pacific. It's HIV and diabetes in the North Pacific. And this is contrast to another Oceania country, Australia. You can see that there's much less TB. And there's also kind of a bit of a problem with self-harm and some of those impacts that we can expect to see rise with climate anxiety and things like that in the region. The reason I want to really highlight the Pacific Island nations is that these island countries are global sentinels for the effect of climate change on dual disease burden of communicable and non-communicable disease. And if sea level rise continues along projected rates, by 2050, 800 million coastal dwellers could be experiencing some of that kind of intersection between climate change and disease that the Pacific Island nations have been grappling with for decades, and in which they have incredible experience and knowledge. So the main question that we were identifying as part of this analysis or exploration was to understand that there's a lot of money that's being poured into the Western Pacific by donors, particularly for active case finding for tuberculosis and other preventative and primary healthcare endeavors. And there's also strong political will within countries to implement these programs, but there hasn't always been successful partnerships that are actually improving these primary and preventive health outcomes. So looking through the lens of tuberculosis, we performed exploratory qualitative interviews with 2 informant types. There were 6 interviews with 6 country ministers of health or their designates, and also high-level representatives from 5 of the major regional health and technical assistance partners. And I'll refer to those as development partners as we go along. And what was immediately obvious when we started this analysis was that the Pacific Island context is unlike anywhere in the world, even if you are familiar with remote settings. So as an example, there are small population sizes from 300,000 to 11,000 different country populations. In Tuvalu, as an example, there are maybe only 3 or 4 people who are the core people in the Ministry of Health. And funder demands can kind of really divide those people and their attention. There's also, unfortunately, while there is a rising birth rate, there's also a decline in population sizes further as there is outward migration. So that is specifically from remoter outer islands to central population hubs and then outwards to bigger Western countries. So that obviously contributes to brain drain and loss of expertise in the countries. And then there's also the outer islands themselves. Just to quote one country leader, he says that if you were to go to an outer island, it would be as if I'm stepping back pre-World War, pre-First World War. Very, very, very basic, it's hands-to-mouth existence. So the inequality divide between the outer islands and the main islands is a source of significant political tension. And what we see is that there's also significant geographical variation. So there are atolls that are very low lying, 3 meters above sea level, right on the Pacific. And then you've also got places like the Solomon Islands, where you've got 3,000 meters in altitude for some of these mountains. And so you can see that what it means to be remote varies dramatically within the region. And where tuberculosis is centered is it's typically an extremely centralized system on the main islands, and that the outer islands may only have a health clinic and not even have a nurse or a doctor. Often this is just a healthcare worker or a medical assistant, and they're doing everything, all of the primary and preventive healthcare. So I won't go through this diagram very closely, but it's essentially looking at how the context of the Pacific Islands is inextricably linked with all of these healthcare priorities. So if we look at one country leader said that these priorities interlink tuberculosis, NCDs, and climate change, they're documented as numbers 1, 2, and 3, but they're actually all key priorities for the country. They don't differentiate. One leader said that climate change is driving these diseases, not just traditionally climate sensitive or zoonotic diseases, but also diseases like NCDs and tuberculosis. So that scope of climate sensitive disease is really much larger than what is traditionally associated. And just to really summarize this, one country leader shared the story. She said, it's sad to see that climate change is affecting our health. I see in the region I live on, I don't see a lot of tuna fish anymore. I don't know if it's climate change or if it's because of the big shipping boats. And then there's the sea rise. It comes over the small islands, has ruined taro batches where that's their main crop for the island. If it affects their main local crops, imagine what's going to happen to those diabetic patients living on those islands. So then they go to rice and canned meats, and climate change is affecting everyone in the islands. The Marshall Islands, Kiribati, Federated States of Micronesia, everyone is affected. So unfortunately, this context of the Pacific really does collide with the way that funding is provided globally. Most of the public health staff in the Pacific are fully funded by either the Global Fund, the CDC, or other organizations. One country leader said, "I keep telling my bosses, if the donors cease their funding, you will have no employee in your department." So this partnership is critical to driving forward primary and preventive healthcare under the current system in the Pacific. And just to summarize some of the ways in which global funding practices collide with the context of the Pacific. The first is that funder mandates are often extremely vertical, and they don't always accommodate these interlinked priorities in the Pacific. Even if they say that they do, I spoke to one funder that focuses on tuberculosis, and they said that we're open to collaborating with diabetes, but we're not going to fund that or facilitate the integration. So in that scenario, you can see that country leaders are required to take the initiative in an extremely complex funding structure where there may be very fragmented funders. They might have 10, 20, 30 different funders that they would need to coordinate. Unfortunately, that's incredibly challenging to do because the funding structures don't overlap. So CDC might have a funding period that halfway through is when WHO are planning their funding, or the Global Fund or the Asian Development Bank. So it's very hard to streamline these plans, and they also have reporting structures that are very different and hard to navigate, particularly when you're losing a lot of expertise in navigating those processes to outward migration. Thirdly, the funding decision makers are not based within the countries they support. So it's not like Zimbabwe, you might have a WHO office down the street. There's actually one base within the region that would navigate the distribution of funds for 14 different island countries. So you would have WHO in Manila, you would have someone else in the Solomons, you would have World Bank in Fiji, and so they're not even interacting geographically, let alone having boots on the ground who can adapt by country. And as we've seen, it is geographically extremely different region. There's a lot of variation. And finally, because there's a lot of geographical isolation in the region, it means that the inefficiencies of funding, when it's not working, is often not seen. So one funder here described that she visited a health facility that was on top of a mountain. There were 100 steps, and it was for disabled. It was a disability clinic, and that the testing there was an entire laboratory, but the lab personnel were only skilled in testing for malaria because that was the consequence of vertical malaria program funding. So Pacific leaders are extremely skilled at kind of navigating this complex health system, and often by intention, but sometimes by accident, have managed to bend these systems to their will. And one of the most successful strategies that has led to improved preventive health and primary health outcomes, including tuberculosis, has been integrated community-wide TB systematic screening. So one country leader said, "We don't deliver these services alone anymore. It's a necessity because we don't have the resources. We bundle it up with other services." Actually, dental is a very big draw card. People participate because that's a felt need. So just to quickly summarize in the last few minutes, when we are to consider what were the characteristics or hallmarks of what countries managed to do to improve their primary and preventive health outcomes, one of them was that consistently stood out was that they had strongly motivated internal leaders, many of whom had benefited from international experience, and they'd taken that and rather than transposed models in other settings, they had adapted them based upon their unique knowledge of context. So really adapted services with a strong country leader. There was also islands that had fewer funders were more able to organize integrated community-wide screening. So this was normally the Northern Pacific Islands that only had the World Bank, the WHO, and the CDC as their main funders. So they could push back and say, no, we want to integrate. And there was always pushback. There was always a no first, and then eventually integration happens. The integrated community screening also was found to promote decentralization, so narrowing that inequality gap as they reached outer island communities. It demedicalized, so for example, people don't want to come to a clinic setting because it makes them nervous, but when it wasn't held in a clinic, there was higher participation, and there was higher community uptake and destigmatization because these programs were combined with things like NCDs and dental, which were less stigmatized and that the community really wanted. And finally, primary and preventive healthcare outreach to the outer island communities did ease many of the political tensions between outer island politicians and central island politicians, and that meant that there was a lot more support from the system. So this is my last slide. I'll just share some recommendations from this finding for development partners. Please streamline your funding cycles and sort yourselves out. It's a huge burden for very small Ministry of Health teams to streamline all of these funding agendas. Please adopt inclusive remits for the use of vertical disease funds. Screening for diabetes, when this is the major driver of TB, is TB funding. And implementing a regular platform for that coordination, which was done by one country and was consistently held up as a good example of what other countries would want. For country leaders, be persistent with funders. If they say no to what you say is needed in your country, keep pushing back, have a clear vision and specific ask, explore alternative domestic funding avenues, such as using tobacco taxes to fund active case finding, as they've done in the Marshall Islands, and invest in external training opportunities for future health leaders. And for TB researchers, this is mostly us. Please integrate TB screening with non-stigmatized conditions so that which meet community felt needs, even if they're not comorbidities, to increase uptake of programs and demedicalize the spaces where care is delivered to stop intimidating people. I want to thank the two major leaders on this study, and Sarah Benays and Ben Murray, and I'm grateful for your attention.
Thank you so much, Michaela, for this talk. Please keep bringing your questions to the chat, and I want to thank Edson and Joanna first for reminding us about to have person-centered interventions. I want to thank Tasha for bringing us how to engage communities and how that can shape social interaction and behavior. And finally, Michaela, for showing us that political leadership and climate change shape TB care and TB care. So now, thank again to all the speakers. We'll move now to the panel discussion that will be led by Dr. Anka Vasilou. And please keep posting your questions. Anka, to you.
Thank you very much, Celso. Hello, everyone. It's great to be here. It's great to see so many engaged and wonderful people online. So my name is Anka Vasilou. I'm a medical doctor specializing in public health. I work as a postdoc for Baylor College of Medicine and also as a clinical epidemiologist for Research Center Borstal in Germany. My work focuses mainly on TB screening and also diagnostics in high-risk populations. So very young children, people living with HIV, pregnant women. I'm very, very happy to be chairing the discussion today. And we'll start with a summary question for Edson and Joanna. So your stories were heartbreaking, and we see in the chat many people engaged and many people were interested and commented on your story and on your feedback. So how can we do better? And this, yes, it's for you, it's for the TB survivors, and we're interested in your opinion on this. How can we improve TB services. So in your opinion, what would be the ideal TB service provided to a person newly diagnosed with TB?
Hello, I'm glad to be back again. I think for the TB patients, what can be done is having to go to the clinic and having everything done under one roof. For example, you get your TB treatment, you get the cancer screening, you get your diabetes screening, you get your screening, and you go to diabetes screening. And also for the TB patients, maybe having nutritional guidance, empowering them financially, like having projects that they do and they get money for their survival from the projects.
Yeah, that's beautiful. That's great. Thank you so much. So integration services not only for TB, right, but for other pathologies that are associated with TB. So yeah, thank you so much. What would you think from the patient perspective of community activities? Would you like people to come to your household, or would you prefer to go to the clinic?
I prefer to go to the clinic, and also in some instances coming to the house, because there is need, I'd forgotten, there is also need for counseling for the people that live in my household, because when I had TB, it affected my children as well, and they did not know what to do with the stigma and the discrimination.
Yeah. Yeah, that's very true. And it's so important. Counseling and household contact screening, TB screening is very important. So to everyone online, please remember you can always put more questions in the chat, or you can also unmute and spontaneously talk. That's not a problem. So let's continue with the discussion within the panel. So we see what the TB survivors, what the TB patients want and prefer. So now my next question is for Tasha. So you provide beautiful services with the NGO and very nice outreach in South Africa, outreach programs. So first of all, is this something that happens all over the country, or could eventually be scaled up all over the country? And what do you think of this integrated care? Is it something that you can provide within like your services in the future with the NGO, or like what do you think of this feedback?
Yeah, so I think good questions, and also thank you to the other panelists. Really interesting work. I get the scale question a lot. So we don't routinely work in other areas of South Africa, except we have now started working a lot in the rural province that I mentioned, called the Eastern Cape. So we've moved from a very urban area to starting to build programs in a more rural area. Theoretically, the work could be scaled and could work in other parts of South Africa and other similar settings. All of that scale needs resource and training and capacity development, and all of that needs time and resource to do. So theoretically, it can be scaled, but it needs lots of investments of both time and, I guess, funding. The integrated care question is really interesting. I also hear from people who have multiple health challenges that integrated care would be really important. And just thinking about Michaela's talk, I think a lot of the way our healthcare systems have been set up, particularly in South Africa and other LMICs, is partially a result of what the funders have asked for. So we've got these vertical programs that are not very integrated. And I think that's been quite a big discussion with a lot of the funding cuts that have happened is, obviously it's very bad, but what opportunities do we see going forward? What silver linings do we see? And I think one of the silver linings that have come up is, can we reimagine a healthcare system where things are better integrated? So, all of you would know that donors would fund an HIV program, but actually people need to have HIV and cancer and TB and diabetes care, as Joanna was saying, all in one. So I do think that with all the difficulty around the funding cuts, and I'm sure these conversations have been happening among all of you, there are moments to reimagine what we do in healthcare. And I think it's nice to hold on to that for a bit of hope. And then finally, just a final point around that is, I do think within that reimagining, putting communities at the center, rather than having a top-down approach, and taking TB survivors' information and community engagement programs and really integrating them is going to be critical, and also for building trust in new programs. So yeah, I'll stop there, but thank you.
Yeah, thank you so much for this beautiful answer. I completely agree. And there's there's a balance, right, between what the funders ask for and what us as researchers would like to do. So this actually brings me to a question for Michaela, who talked about this subject. We have these funders, they have their agenda, they are saying this and that. Sometimes communities push back. The funder says no, they push back some more. So you gave some recommendations for all types of actors. Can we expand a little bit, Michaela, on what can we do as researchers, right, or implementers here online? Is there something that we can concretely do next year to improve this kind of environment?
Thanks, Anka. That's a great question. I think what we have seen is that, or at least from my perspective, there is a trend towards integrated care and providing integrated services. But there does seem to be resistance from the perspective of, I guess, the more kind of biomedical or rigorous, like trained researchers would say, oh, where are the outcomes? How can we measure this? If it's not related to TB, how can we use funding? It's outside of our remit. And so I think every researcher taking the perspective that if this is a disease of inequality, as Tasha said, which it is, then we can no longer view TB as the only. If we want our TB programs to work, we have to care about the whole person, the whole family, as a kind of base for how care is delivered. It's not person-centered care often, it's family-centered care, and that extends beyond the period of treatment. So I think that kind of paradigm shift in our minds, and then I guess for researchers, finding ways to conduct this research, getting rigorous outcomes, including the knowledge base, and doing it in such a way that is not based upon what has been done before and just kind of one extra step. We shortened the regimen, although hugely important, but actually radically looking at the way, what do communities want? And if they want dental care, and that's what's going to get them into screening, even though that has nothing to do with TB, that's part of our remit to care for the person and the family. And as TB researchers, there are very few people standing in that place of being in that position to say we have a disease that is so associated with inequality that perhaps we have a responsibility to interact with that space as well.
Yeah, thank you so much for that answer. So yeah, really we need to have more of a bottoms-up approach and actually properly assess the needs of the communities that we serve. Yeah. And also speaking of community and household screening, Deborah Vambe from Eswatini commented that we often forget counseling, but it's so important. So this was going back to the RTB survivors saying that counseling for them it's so important. So yes, I want to highlight that within the group. So now moving a little bit to the TB program and generally, so we have a question in the chat first about the DOTS strategy. So I don't know if someone from the panel wants to comment about the patient experience with DOTS, maybe our patients, right? So our TB survivors. So what's your experience with DOTS, and how do you feel with this strategy? because there's some mixed evidence in research. Edson and Joanna.
Okay. Joanna, the question is, I'm talking about your what's your take about DOTS? Is that am I correct answer?
Yeah, it's when you have to take the pills in front of a in front of a clinician, so they make sure that you took your pills, and yeah, it's this kind of directly observed treatment. Yeah.
Exactly. So before she responds, I will give you a platform to respond. In Zimbabwe, we transitioned from a period of strict dose, where a patient was required to take each and every single pill in front of a clinician every day. And in several regions, of course, that is still being implemented in few regions, maybe 1 or 2 regions, but in several regions, they are now like giving you at least 2 weeks supply with the support of expert patients, peer educators, community healthcare workers. They will be just supporting you to make sure that you are not defaulting. If you have got any questions, you may want like any worries, but otherwise they are now being given every 2 weeks to a month supply. But I believe during Joanna's time, it was strict dose, everyday pill, So what's your take, like maybe during your time, daily dose to what's happening right now, your experience?
Yes, thank you. During my time, it was time consuming, and you had to use transport to go to the clinic, and you had to excuse yourself from work. It was very laborious. But now because they are being given the 2 weeks regiment, and then you come back after 2 weeks. But there are some people who are still being put on those people who are not taking their medicine religiously. But I think now you can take your medicine whilst at home, and if you are fit enough, you can continue with going to work. So it's very good. It's better than it was before.
Yeah, okay, thank you. It's good to hear that many patients actually take ownership of their own treatment, and obviously they're adults, they can take their own treatment at home. They don't need to be treated like young children and checked every single day. And actually it's also good to hear that there is a specific group of patients who can actually benefit of this strategy, because they do have issues taking some people sometimes do have issues taking treatment. But this comes back to counseling. This comes back to actually finding the root cause of why is it so difficult for them to take ownership of their treatment. So interestingly, it might be something to explore over there. So we have another great question from Michaela in the chat, directed to Andrea and Marcelo, about integrating cardiovascular disease and respectively post-TB lung disease, and how can this be provided, how can this surveillance be done and be provided in a demedicalized way? And if I'm not doing justice to your question, Michaela, please go ahead. Okay. And also I would add to this, because it's what I was trying to get to integrate everything in the discussion when I started discussing about the NTP. Do you think we should actually integrate this as a column in the TB register, like cardiovascular disease? Yes, no. Post-TB lung disease, or do we have to see every patient 12 months after diagnosis? What do you think of this?
Could I start, Michelle? Yeah.
Thanks,
I
yes.
think it's I think it's difficult to answer this question. So I think the NTP is best placed to inform the patients about the potential of an ongoing health problem resulting as the consequence of TB. And I think it's natural that they are the first stop, or the first institution or of the health facilities to to diagnose patients that need immediate healthcare, because there are these TB patients that develop very early problems. Yeah, so from the TB cough, they develop a kind of chronic cough. There are very few patients though, but they are there who develop already right heart failure very early, around the end of TB treatment. Yeah, and also in the months after end of TB treatment. So I think here it would be important to extend the follow-up time and include in the assessment of recurrent TB or the establishment of TB cure status also the assessment of respiratory consequences that need immediate health care. Yeah. At the same time, also NCD clinics and primary healthcare clinics see post-TB patients among patients with other chronic lung diseases, asthma, COPD. And it's equally important that they have certain understanding and also tools at hand to diagnose these patients. And we all know that respiratory healthcare is not well developed. Basically, there's not anything existent in some settings where I'm working. So, and I have doubts that patients with PTLD can be treated adequately if we do not try to develop respiratory healthcare in the countries. Yeah, so in the vertical silo or whatever setting, but we need better respiratory healthcare clinicians also in these countries to interlink. Yeah, and that's the challenge at the moment. I had discussions with colleagues also when I defended a proposal to integrate respiratory healthcare in these settings where you often get the comment from pulmonologists, this is not possible, you cannot have bronchoscopy there, you cannot establish spirometry. So, and then you start discussing, and I realized in that discussion that at least in the Western hemisphere, the subject of respiratory disease actually developed out of TB healthcare. So 100 years ago, also in Europe, TB patients were the main respiratory patients clinicians saw, and out of these sanatories, they developed all the respiratory hospitals in Europe or in Germany. There are many clinics like the clinic in Borstel. They started from being a kind of outpost for treatment for TB patients and then became specialized in respiratory healthcare. So maybe the NTP program is a good seed or focal point to start developing respiratory healthcare in low and middle income countries. But yeah, we need funding and we need studies around this, implementation research around this to evaluate what is feasible and what works. And yeah, so.
Excellent. Thank you so much, Andrea, for this. So yeah, definitely a lot more work to be done within this area. Marcello?
Marcello, yes, thank you. Yeah, no, thanks, Andrea, for going first, because I was thinking about my answer, because it is a really difficult question. I think particularly in terms of demedicalizing care in the context of cardiovascular diseases, I was thinking how you would do that, because we rely so much on diagnostics. I think from the relatively limited knowledge that I've accrued. The issue that we have is cardiovascular diseases are vastly different according to different countries. And so the epidemic in South Africa is very different to Zambia. And so I think a lot of the integration of care really needs to be NTP and country focused according to the local epidemiology. And that's an important point. And I think within that, we can say that where the role of cardiovascular disease screening and management would fall in would be, at the moment, the evidence surrounding pericardial and some myocardial diseases, which could be detected in the context of acute TB and thereafter chronic TB. And for that kind of detection, you can do point-of-care echocardiography, which is a simple and easy tool that can be integrated within settings. Although I say simple and easy, it's still expensive. It still requires training. I think with AI, that's going to really increase and improve the game for echocardiography, both in terms of image acquisition as well as interpretation. Again, probably more in the context of screening if we think about sort of CAD for TB. the issue is that we're still only going to be detecting a relatively small proportion of patients. And so in terms of cost effectiveness, do we actually want to increase lots of cardiovascular disease screening in TB clinics? Are we going to pick up that many patients with pericardial and some myocardial disease? We could think about screening tools that use point-of-care biomarkers like BNP and troponin to try and identify those patients a bit more. If we think about the much bigger scale atherosclerotic cardiovascular disease population, the issue that we have there is that we just don't have the evidence really linking the two. However, what we do have is a healthcare infrastructure where there's that strong focus on TB and HIV clinics in many places, for instance, in Southern Africa, where we could improve certainly patient education. We could integrate better with primary care and NCD clinics to look for risk factors for cardiovascular diseases rather than just treating a patient's TB. But again, it sort of revolves back around to that issue of essentially providing primary care that is integrated. I don't know if that's a bit of a fumbled answer, but
It's a great answer. It shows the fact that we don't have many like a lot of evidence, a lot of scientific evidence on what we should do. So we should investigate different strategies to try to find out the one that would be best. And also knowing that one size fits all might not be the right strategy, because as you said, cardiovascular disease might be a different thing all over the globe. So like each country ideally should adapt the strategies. I saw hands up from Michaela,
Yeah.
and now she like
No,
and there's
sorry,
also Michaela, there's also a question in the
question
chat.
in the
So
Okay,
discussion
I'll
and
see what I can.
question. Yeah. In 3
So
minutes.
yeah, okay. Thanks, Andrea and Marcello. I think that was super insightful. And something that really does occur to me is that while we do kind of expand this thinking of integrated screening and capacity within NTPs, it really is a risk that we expect the NTPs to do more and more without adequately supporting them. And my sense is that, you know, the basic functions of the NTP currently, which is caring for people with TB, maybe doing some active screening, following up on treatment, is something that is almost at its limit in a lot of settings. And so when we pile them with extra things, some of the things that should be reasonably within grasp kind of slip out. And so this idea, I guess one of the things that I did see quite successfully in the Pacific, and I'm not sure if this is kind of applicable globally, is parallel workforces, parallel primary supplementary supportive workforces that conduct a lot of these integrated screening. Maybe someone from each department that kind of comes together and rotates through a integrated supplementary force, so that, you know, we avoid that concern of slipping from the primary mandate of looking after people who have TB, but which can also be outward focused in terms of going into communities rather than waiting for them to come to us with advanced disease. So yeah, that was another thing that I was thinking, rather than burdening our NTPs who really have very little power to protect communities from malnutrition and all the things that we know are driving the epidemic.
Yeah, thanks, Michaela. It makes a lot of sense. Like we want them to do more tasks, but definitely more staff and more resources should be allocated. And then could you comment on the Pacific funding environment, and if the international funders are more flexible? Are they doing yoga or not?
Yeah, I think there are definitely some really flexible funders. There is a big push for integration. Often it's not necessarily the integration that is supported, but some funders, I think particularly UNICEF, have kind of been going into clinics and doing full kind of, these are all of your weaker points. We will support you to strengthen your supply chains, your, like all of those things that are needed to support integrated care. It is hamstrung by the absolute loss of expertise. Like the hemorrhaging of staff is extremely high, brain drain to the States, brain drain to New Zealand and Australia. So many excellent staff are kind of rightly are trying to find better opportunities for their families and things like that, which is why community tailored, led by local advocates, is something that is much more sustainable than an external funder coming in and saying, who is good, who is ambitious, like as assessed by Western eyes. So yeah, I don't have a full answer for that. There is an increase to flexibility. In the past era, one of the main funders, Australia, just didn't believe in climate change, not even 5 years ago. So there are also political aspects that have prevented like very good funding and partnerships in the region. But I do see that this is increasing.
Okay, thank you. So let's keep in mind that there is hope, right? Let's like take this as a take-home message. There is still hope. So ideally, we should all go full steam ahead with our work and try to be very mindful of everything that we talked today and integrate this into our work. So thank you so much for the wonderful speakers of today. And also to the audience, you have been very engaged and very active in the chat. So thank you so much. We've made this panel discussion a really great conversation. So we are at time. Thanks for connecting and see you all tomorrow.